morning, everyone. Kia ora. I should thank Susanna for her kind introduction and her kind invitation, and it's great to be here. My name is Hamed Ektiari, as Susanna mentioned, and I will be with you for the next couple of hours discussing about brain deficits and substance use disorder and how we use those ideas for addiction treatment. Okay. First of all, I need to thank my colleagues and collaborators that basically made lots of these things happen, and the kind of different centers that we are running these kind of cognitive education, cognitive training materials in US. I'm based in Tulsa, Oklahoma. I'm not sure if you have a kind of good idea about the US map. We are something like 4 hours driving north to Dallas. So if you know where is Texas, so we are north to Texas. And Oklahoma is probably one of the least affluent part of US, and it's true for the mental health issues. And that's the main reason that I basically moved to Oklahoma. And I really like, because of there are significant needs for mental health treatments, and also there are philanthropic families that they are supporting kind of development of new treatments there. And I'm going to share you the experience that we had in developing treatments, and I'm going to kind of discuss with you how we might be able to bring those treatments to here in New Zealand, so seeing how we might be able to kind of promote them here as well. Okay, first of all, okay, this guy is going probably to make a problem for us, but that's not a problem. But in terms of treatment for addiction, how much are we successful for addiction treatment right now? Okay, how is our success rate? How much we are able to provide people with a reasonable level of abstinence for a while in addiction treatment? And the reality is, in most of addiction treatment centers, our success rate is close to something like 30%. And if we just leave people without any intervention, sometimes their success would be something like 10%. So we are talking about just something like adding 20% with all the interventions that we are doing for addiction treatment. So we are not that much successful overall across the world in addiction treatment. And that is a big problem, okay? So we are going to discuss how we might be able to provide better treatments. That is the main kind of idea that we are going to discuss today about. And if I want to show you some kind of numbers in terms of the success rate, especially for those who are, those who are polysubstance users, the success rate would be even lower compared to, those who are using cocaine or opiates or cannabis. So the success rate would definitely be lower. And most of our patients are polysubstance users. I'm not sure how is the status here in New Zealand, but at least in US, most of the patients I receive, they are using, whatever they can get. So they use everything. And in terms of different treatments that we are providing, as you can see, different treatments are kind of close to each other in terms of the outcome. There are positive things about cognitive behavioral therapy when we join that with contingency-based management. But even with those things, the variation is huge. So we know that at the end of the day, most of the treatments that we are providing, they are almost in the same kind of situation in terms of the effectiveness. Please.
So does the contingency management, is that like aftercare or assertive outreach? What is that?
Anybody in the room that has done contingency-based management? Do you want to tell us about contingency management?
2 years ago, we did some training on contingency management, and it's all about incentivizing behavior changes, and so it's giving minor rewards for achieving certain outcomes. So.
Yeah, that's the kind of the structure. So we
someone a petrol voucher for coming to their
exactly. That's exactly the model. Yeah. Okay. But it's really important to know that those who are in recovery, they have, some of them would be more successful and some of them they are not. So let's start from this scenario. I usually ask the psychologists that work with me about how do you predict who is going to be successful or not. Because that's something like that we do most of the time. When we receive a new patient, we just start to think about, okay, is he or she going to be successful or not? We just start to predict, okay, how would be the success rate? And what are the things that we consider to think about and make an estimate about the success rate? And in my experience, and in kind of many studies, it seems that the higher the level of cognitive deficit that people have, the lower would be their success rate, okay? And that is what we can see in this graph. People showed that when people have lower cognitive functioning, overall cognitive functioning, the attrition rate would be higher. And that is something that, if you do clinical practice in the field, you know that those patients that they have higher cognitive deficits, and the cognitive deficit would be represented in their daily life, in their job, in their family life. And if you have a patient that is really good in kind of his family life or her family life, or in kind of her job or in her kind of community, probably they do not have that level of cognitive deficit. So those who are cognitively dysfunctional, most of them, they are not really functioning in the society as well. So we know that cognitive deficits or brain deficits are going to be really important for recovery. And those who do not have, let's say, good memory functions, how can they attend therapy sessions and learn what we are talking about? How those who have attention deficit, how can they come to the addiction treatment and have enough attention to receive what we are providing them? So we know that those deficits are even important in terms of how people could make a benefit from the treatments that we are providing. So we know that those cognitive deficits are going to be important. But what do we do right now with all these cognitive deficits that people with drug addiction have? We are hopeful that when we leave people and we let them be abstinent for a while, the brain will start to recover by itself. That is the kind of something that we think, that the brain is going to recover by itself. But in reality, and there are many studies about that brain recovery, spontaneous brain recovery is going to happen for close to 30% of the patients. So something like 60 to 70% of patients, spontaneous brain recovery is not going to happen with just abstinence. We need to actively do something. And it has been shown in other brain injuries, in stroke, in traumatic brain injuries, in many other kind of brain injuries, that if you want to have a brain recovery, we need to do rehabilitation. And that is what we do. We do a specific brain rehabilitation for those who have, let's say, stroke, for those who have traumatic brain injury. For many of the kind of brain disorders or brain injuries, we provide active brain rehabilitation to bring brain back to its function. But in reality, for drug addiction, because of many different reasons, we do not do that. In routine clinical practice, we do not do any specific brain training and brain rehabilitation to be hopeful that how kind of the brain would recover in a better speed. So that is what I'm going to talk about. So I'm going to talk about how we might be able to do brain rehabilitation and what are the steps. And we will try to work together. Probably in a kind of 3-4 hours workshop, we cannot do a lot in terms of kind of changing everything, but I hope that this workshop would be a good starting point for you to start to think about, okay, how I might be able to do brain rehabilitation for those who are in recovery, and what are the potentials, what are the deficits, how we might be able to design something, so I'm going to discuss about those things, okay? But let's start from this point. I'm going to ask you to have something to write on. I'm going to ask you to kind of share your ideas, and we are going to talk about those things together. And I hope that we'll ask many questions about these things. So we want to start from this question. Based on your experiences, what are the brain deficits that people who are in the recovery would suffer from? Okay, so what are the things that you feel that people who are in the recovery are suffering from that are related to their brain deficits, their brain injuries? Okay. What are the brain deficits? And what for people who are in recovery? Yeah.
Abstinent or recovery?
They are in their early abstinent, let's say. Okay, let's say they are in, let's say, second week Or even you can talk about those who are, I'm not going to make that too much specified, but I mean, you know that there are definitely changes over time. But even who are not in abstinence, those who are treatment seekers, they just attended and they really like to be a part of treatment, what are the deficits that they are suffering from? Okay? So we have, let's start from this question. What are the brain deficits? What are the brain deficits and how, I mean, even if you want to rank them from, let's say, 1 to 10, what are the most frequent ones that you already have?
Emotional dysregulation.
So emotion regulation, 1. Memory deficits, 2. What else? Attention, lack of attention. Executive functioning. And how do you define executive functioning? Organizational things. Okay, good. What else? Difficulties in planning. What else? Donna, what do you think? Impulsivity. What else?
Foggy brain.
Boggy brain, okay. What else? What else? Confusion, okay.
Often comprehension.
Lack of comprehension, okay. What else? Lisa, what do you think?
I think it all sounds like ADHD.
ADHD. What else?
I think anger issues, controlling anger.
Jin, right? Anger issue, kind of problems with anger management. Anger management. Okay, so you have beautifully mentioned different things that we have with these people in substance use disorder. We have, let's say, anhedonia. Sometimes they have, when they are in the recovery, just feel that nothing would make them excited, or just feel that they do not have anything around them. Or they have psychosis. That is another kind of representation of brain injuries. Or they have issues in terms of their social interaction and their communication with others. Or they have learning, attention problems. So there are many, as you have mentioned, there are many brain deficits that we face among people who are in the substance use programs. If we want to give you something like a model, I'm not sure how much we are going to go into details, but I would definitely be happy to go to more details about what are the specific kind of deficits that we know about substance use disorder. So there are specific models. For example, the simplest way to categorize the deficits that we have in the field would be dividing them in 3 major groups. One would be related to control, incentive salience, and negative emotionality. So incentive salience would be just enjoying from drugs and not enjoying from any natural pleasurable activity. That would be the incentive salience side. And the negative emotionality would be stress, anger, all the negative feelings that the people would suffer from, all the kind of the craving that would be related to the negative feeling, withdrawal, all those things would be negative emotion. So these 3 would be the major groups, if I want to categorize them in 3 major groups. And then we need to add some other things to those 3, let's say, major groups. There are problems with the sleep, and problems with the sleep is a part of the brain dysfunctions that they have. There are problems with their interoceptive processing. What is interoceptive processing? How they feel what is happening inside their body, how their brain is connected to body. So we know that they have problems in terms of what is happening inside me, how I perceive what is happening. And sometimes their even lack of insight would be related to that, because they really don't know what is happening inside their body. I mean, the level of deficit that they are suffering from, or the level of injury that they are receiving from drugs, is not really clear to them. And it happens to you when you just feel in the morning that I have fever and it seems I'm not functioning well, and so I need to take one day off. It seems I'm getting a cold, so I need to take care of myself. That is what happens to us. Those who are in the kind of substance use, sometimes their body is not connected well to their brain in a way that they do not have any kind of good understanding about all the medical disorders that are happening inside their body. And sometimes they feel that I'm doing well, When you are from seeing them from outside, you see that, okay, it seems that they are not doing well, but the reality is that as they are not that much well connected to their body, they cannot listen to what is happening in their body, and that makes them not being able to understand. So that is another dimension that should be considered. And the other thing that people think that is an important part is what we call metacognition. And metacognition means that I have an understanding about what is happening in my brain. It's called cognition over cognition. Do I know what is happening? Do I know what are the problems that I'm facing? And metacognition would be a core component of insight. Sometimes I do not have any enough kind of reasonable insight because I really don't know what is happening inside my brain. And then we can merge them to another model that is called a combination of having the aversive side, appetitive side, executive side, and then some processes that are in the middle, and some upper function that are metacognition and social interaction that are. So there are different models that try to kind of put these deficits together to provide us with an idea about the problems that people in substance use disorder are perceiving. And if I want to give you kind of the names of these models, I'm not sure how much people are familiar with NIDA. NIDA is the National Institute of Drug Abuse in US. And these two are basically NIDA models, and this one is NIAAA model. And NIAAA is the National Institute for Alcohol and Alcohol. So that is the alcohol side, and also so these are the main models that we use in US in terms of having an understanding about cognitive deficits or brain deficits related to substance use disorder. Okay, but I'm not going into the details about that. Just giving you a few kind of overviews about what is happening. And if you have a specific question, I would definitely be happy to discuss about the details. And there are some, let's say, neural correlates for these functions and how these functions are happening across the time. I'm not sure how much people would be interested to go to the details of the brain areas that are involved. So we know that as we have been discussing about, let's say, these kind of, let's say, tripod model, okay? So we can see that different areas in the brain would be related to these green, red, blue parts of the cognitive dysfunction, okay? And we know that these dysfunctions in something like a circle for those who are in the daily use of drugs would be alternating. So for those who are using the drugs, they are mainly kind of bringing in the areas that are related to the incentive salience. And then when they are in the withdrawal, then the negative emotionality would be more dominant. And then when they go to the kind of preoccupation, anticipation, drug seeking, so they are looking for drugs, then the executive functioning would be more involved. So we know that these dysfunctions are not static. So based on the status that they are, if they are in the withdrawal, if they are intoxicated, if they are right now looking for drug, different cognitive functions would be involved and different deficits they would experience. So it's really important for us to have an understanding that these cognitive deficits or brain deficits are not something that are exactly the same in the morning, in the afternoon, day 1, day 2, day 3. They are going up and down based on the status in the process of recovery or in the process of substance use. And they change across the time as well. So those who have been using drugs for 1 year, they have a sort of kind of different mechanism or different dynamism between these deficits. And those who are in the substance use for a longer period of time, we can see that they start from something like a reduced energy to reduced excitement to just being restless and depressed. So there is a change across the time for these deficits. We know that those who are in substance use for, let's say, 20 years or 10 years or 5 years or 2 years, they have different levels of deficits. And we know that it's not something static. It's a process that would be different across the time. And what we do for treatment, in the treatment we can target these deficits. that is what, I mean, we try to do in the treatment. We try to, let's say, improve their executive control. We like to reduce their drug preparation, anticipation behaviors. We like to lower their kind of negative saliency for abstinence, higher negative saliency for drug use, or lower positive saliency for drug use, or higher positive saliency for natural rewards. So that is what we do in treatment. We try to target these functions and move forward to see how we can improve the treatment. But going back to a kind of a more comprehensive models, that are basically the NIDA models, what are the specific things that we do in the process of recovery for these deficits? How we can target these deficits. And that is what I'm going to discuss today about. So I'm going to kind of start and introduce each of them and discuss about the problems that are associated with them and the things that we can do for them in the process of recovery. That is the target that I'm going to discuss about. In the first session, I'm going to talk about what we call cognitive education. And what does it mean? I will discuss about that. But we will discuss how cognitive education would work in the process of drug addiction. And then in the second session, I will go for rehabilitation. So how can we do brain rehabilitation? So this is how I basically divided the slides and the topics that we are going to do. And I have lots of kind of good handouts for you on the back of the class. I will bring those handouts, so we will work on those things together. Okay, we name addiction as a brain disease. That is what that is how we communicate with patients. That is how we know addiction. We know addiction as a brain disease. That is what do we agree on that or not? Yeah. Okay, is it, any doubt about that? Is it it is not probably a heart disease or a kind of, so that is is this, we know that there are definitely problems in liver, there are problems in many parts of the body, but the core problem in drug addiction is about brain. Agreed? Okay, so if we talk about addiction as a brain disease, how much information we provide for our patients about this brain disease? I receive a patient, I start with the patient, I'm telling him that, okay, drug addiction is a brain disease, okay? Then he will ask me, okay, if it's a brain disease, how I can help my brain to recover? What are the things that I can do for this disease? So there would be lots of questions, okay? How can I kind of do something for this disease? That's happening for all of us. So let's say that you go to a kind of clinical care and you have, let's say, vertigo, okay? So you have a level of dizziness and you just feel that kind of the room is just, you just have a level of kind of lightheadedness. And then, after some of the lab works, they would tell you that you have mal-debarkment syndrome. Okay, have you heard about that syndrome? Okay, so you have mal-debarkment syndrome. And when I kind of tell you that you have mal-debarkment syndrome, what would you be asking me after? First, what is this? What else?
What's my prognosis?
What will be my prognosis? What else?
How do you treat it?
How do you treat that? What else?
How long will it take to get better?
How long would it take? Okay, what else? What else you would ask? Could it be prevented? What else? What else do you actually to know about something that you have just got?
Would I die from it?
Would I die from that? So what would be the prognosis of that? Okay.
Why did I get it?
Why did you get that? Okay, what else?
How long do I have to take treatment for?
Okay, how long the treatment would take? Okay, what else?
Where do I have to go to get treatment?
Where should I receive the treatment? What else?
Is it inheritable?
Is it inheritable or not? That is a good question. What else?
What caused it?
What caused that? What else? So you start to think about, okay, all these questions are relevant. So you start to think about all these questions, okay? When we start to talk about drug addiction as a brain disease, if patient starts to ask us about these questions related to brain, okay, how long would it take my brain to recover? Okay, what can I do for my brain in the process of recovery? What are the answers that we are providing right now? Okay, and in reality, when you go to other medical conditions like diabetes, okay, you know that those who are suffering from diabetes, they would not recover, they would not have a reasonable kind of level of performance without having an intensive level of education. So if you want to be able to control your diabetes, you need to know what is happening. You need to know what is hemoglobin A1C. You need to know what is blood sugar. You need to know what would be the macrovascular and microvascular problems that diabetes could make, and how can I prevent that. So across the world, people would receive specific diabetes educations, and there are specific courses, there are specific even counselors that are being trained to provide people with specific education about the disease by itself. Because if you have diabetes and you want to control your diabetes, you need to know about even different mechanisms that are involved. So you need to know about how your retina is going to be affected by diabetes, and how controlling your blood sugar is going to help, or how you might get something like a hypoglycemic shock. And if you don't know how hypoglycemic shock is going to happen, or how your medications could make the hypoglycemic, so you need to know these things. Otherwise, your life would be in danger, or your recovery would not be happening. Okay, so that is what we do for diabetes. What do we do for addiction as a brain disease to educate our patients in a way that they can use those kind of educational materials to help their brain in the process of recovery? That is the question I'm going to address right now. And you might ask, okay, do we know enough about addiction as a brain disease to communicate that knowledge to the patients? You might think that, okay, we don't know very much about addiction as a brain disease, so that's the reason that we are not communicating with patients about addiction as a brain disease. So is there a lack of science about that? I recently published a textbook on neuroscience for addiction medicine. Okay? It has 38 chapters, close to 1,000 pages, 120 authors from 55 institutes from 14 different countries. So it's a textbook, and there are many things that we know about neuroscience for addiction medicine. We know many things about addiction as a brain disease. But how much do we communicate that knowledge to public, to patients who are suffering from addiction? Okay? So what are the questions that patient might ask? So I'm going to discuss about that. So we have to start to think about, okay, we need to develop a neuroscience-informed psychoeducation for addiction medicine. We need this. We need to provide our patients with information that is going to help them in the process of recovery about their brain. That is what I realize that we need to have. I'm going to discuss about that, about kind of what are the things that we're providing and how you might be able to use the material. And I brought most of those materials here today, so we will have those materials to be able to use those materials to communicate to your patients. That is what we are going to do today. Okay, that is the target. And all those materials, the kind of the files and the workbooks and other things are going to be available online. So we are going to share those materials for you. So you can take them, you can print them out. So that's what we are going to do today together, okay? What are the potential areas for neuroscience-informed psychoeducation? Let's think about the things that people might ask. As I kind of told you about mild debarkment syndrome. Okay, what are the potential areas for neuroscience-informed psychoeducation? 9. What are the things that we can do? First, how dependency happens in the brain and how it recovers. How much do we know about this? Okay? What are the neurocognitive deficits that people would suffer from, as we discussed about? And how do they make a significant effect on the recovery or on the normal function and daily function? Okay, just to kind of start with those two kind of problems, and a model would be helpful because I think that we will discuss about this model. This is a model that we developed. When we talk about kind of mechanisms involved or brain deficits involved in drug addiction, we need to know that there are 3 major neural mechanisms involved in making brain injuries in the process of drug addiction. Okay, it's important to know. We have 2 major mechanisms. What is called neurotoxicity. So drugs are neurotoxic, okay, and make your brain injured from drugs. The other mechanism is called neuroadaptation. Neuroadaptation doesn't mean that it makes any toxicity. It just changes the brain in a way that brain would be a different brain. So we just make a brain a different place. And when we talk about different drugs, for example, when we talk about nicotine is not that much neurotoxic. The main problem with nicotine is that it makes lots of neuroadaptation. Okay, so that's the kind of the change that it makes. Or other drugs, for example, when we talk about ecstasy is mainly neurotoxic. It's not that much towards the neuroadaptation. So most of the people who are using ecstasy, it's really not that much frequent to see a patient who is dependent to just ecstasy. Okay, so it would be something like here. So mainly close to neurotoxic, but not that much neuroadaptive. But things like nicotine would be here because it's more, let's say, neuroadaptive compared to neurotoxic. Okay, these two lines, and then we have some neurodevelopmental issues as well. So people who are in drug addiction, most of them, they have a sort of a vulnerability from before. So they had a neurodevelopmental issue in terms of their executive functioning. Some of their functions might be even impaired from childhood. So we know that. So when we talk about the specific kind of clinical features of cognitive deficit, we are talking about these mechanisms working together to make a clinical picture. And each of them could be involved in the process. And when we talk about, let's say, a specific problem, so if the patient has a specific stress emotion reactivity problem, or you have mentioned anger management. If the patient has an anger management problem, the anger management could have roots in neurodevelopmental issues, it could have roots in neurotoxic parts, and it could have roots in dependency. So there are, these 3 parts would be contributing to the problem like this. And things, I mean, when we talk about a patient with decision-making difficulties, it could be something like in the middle. When we talk about cue reactivity, or let's say craving, when we talk about craving would be here, mainly from the neuroadaptive side, a little bit from the neurotoxic side. So different cognitive functions would be in the spectrum of interaction between toxicity, dependency, and the problems that they have from childhood. So these 3 main factors would be contributing to the problems, okay? Going back to the list of potential areas for 9. What are the neurocognitive processes that are involved in lapses or relapse, or involved in overdose? We realize over time those who have more overdose experiences, they have lower cognitive functions. Or those who have multiple relapses, they have lower cognitive functionings. Because it seems that in every time that people get abstinent and they restart to use drug, every time they just go lower in terms of their cognitive functions. So one of the major predictors of how much people have significant cognitive deficit is how many times they have been in rehab. So the more frequently they have attended in rehab and they turned it off and on, even they would have lower cognitive functions compared to those who have been using drugs constantly. So making on and off would make things even more complex. That is what we do with methadone. I mean, most of the time when we provide methadone, it's really important to make the methadone something like really stable. So if you have a patient that is using methadone, let's say like PRN, they have methadone on their pocket, whenever they feel that they have a withdrawal, they just take one pill of methadone. That is going to act something like a drug, because they just go up and down with that. As if they use methadone in an up and down way, if they get withdrawal and then intoxicated and withdrawal and intoxicated, that is how these drugs would make a toxic effect inside the brain. So if we make the methadone really stable over a time, they would not have any kind of major toxic effect. So methadone or opioids, most of the time they are not really toxic by themselves. The problem with opioids is that they make intoxication and withdrawal, and those intoxication experiences and withdrawal experiences would make that the problem. So we know that those kind of parts, how do they contribute to the recovery process? And what are the neural or circuits that are involved in stress-induced craving and cue-induced craving? And how much are they different? When I feel that I need to smoke when I'm stressed, or when I feel that I need to smoke when I feel that others are smoking as well in the room? Okay. And what are the differences between these? Have you had a question, David? Yeah.
I was talking about alcohol is the substance that we most commonly work
Yes.
with. So there's a kindling effect, with people who have multiple detoxes, and then they start drinking again soon after that detox, and then they become progressively more unwell. Their withdrawal is more difficult to manage. Their recovery is less. So that's more or less what you're talking about.
Exactly. That's exactly what we were talking. Yeah, exactly. That is, those multiple, and we know that every time that we do the detox, it is a really good process. It's a really good start, but we know that each detox would be associated with lots of brain toxicity as well, because, okay. What is the roadmap for brain recovery? If I have an attention deficit, how long would it take to get my brain back in a way that I would not have the attention deficit? How long the attention deficit recovery would take? How long would it take to have normal executive functioning within the recovery? What is the time course? Okay, when we do treatment for people, let's say in diabetes, we can clearly know that, okay, this medication would take that amount of time for this specific thing to happen. And what about the recovery, brain recovery for drug addiction? These are the other questions people usually ask. What are the effects of different medication if I'm receiving Suboxone, if I'm receiving Subotex, or if I'm receiving methadone? What is the effect of methadone on my brain? Okay. What is the effect of different psychotropies? Let's say if I'm doing mindfulness-based relapse prevention, or different mindfulness, or if I'm receiving contingency-based management or CBT, what are the effects on the brain? How lifestyle could be helpful for the brain recovery? How can I change my lifestyle in a way that could be helpful for the brain recovery? And how can I actively rehabilitate my brain? If I'm really motivated to do something for my brain, what can I do for my brain? Okay, we realize that these concepts are really sometimes complex to communicate with patients. So they might feel overwhelmed about these things. So we start to think about, okay, we need to make them simpler, understandable for the patients. And we realize that we need to have cartoons to make things simple. Why? Cartoons are attention grabbers, and they grab attention. They are memory friendly, right? They help patients to reframe. What do we mean by reframe? And they could be sort of heuristic tools for decision making. Let me show you one cartoon. What do you get from this cartoon? We usually show this cartoon to patients when we want to talk about how being in rage or an intensive emotion could be detrimental for their recovery and for their brain health. So we say that, okay, if you get in rage or if you get in negative emotions, those negative emotions would be something like putting your brain in the fire. So they are going to kind of disrupt the process of your brain recovery. So if you want your brain to recover, you need to keep it out of that fire. Okay? So that simple cartoon could transfer the message. And most of the time, patients just have that simple cartoon in their mind. Whenever they just want to get kind of in the kind of anger, they just feel like, okay, if I want my brain to recover, I should avoid. I should just try not to get angry, because getting angry is going to be detrimental for my brain recovery. So trying to provide cartoons that could help patients to reframe the environment that around us, around them, and also kind of use them as a heuristic method to think, okay, I'm just going to kind of avoid any condition that would make that problem. Okay. And we realized that cartoons could be really good for self-awareness, trying to aware people about what is happening inside the brain. Let me just make an example for you. We realized that patients, we need to develop cartoons that people relate themselves to them. If you want to provide self-awareness, cartoons should be relatable, okay? I'm going to provide you a few cartoons and you tell me which one do you like more, and you relate yourself more to. And we develop cartoons for both male and female. Today I'm mainly focused to the female cartoons because it's kind of less frequent to have any treatment specified for women in the field of substance use. So this is what we are going to discuss. So character 1, character 2, and character 3. Which one do you relate more to? Or you think that your patient would relate more to? None of them. You must say none of them, okay? You need to select from the 1 or 2, 3. I will provide you with a few other examples.
Number 3.
Who is with number 3? Number 2.
No, I'm number 3. Number 2 is too mumsy.
Number 1. Number 1. Okay, good. So let's see a few others. Which one do you like?
Number 2.
2. Number 1. Which one do you like more? Number 1. Who is with number 1? Number 1. Number 2. Okay. Number 3. Okay. Good. So we have done these studies, and I work in kind of US. So we try to find characters that are not that much kind of oriented to a specific race, whether it's black or white. So we like this character because it's really hard to say whether she's white or black or just less differentiated. So we move forward and we started to develop cartoons. And we started to communicate those cartoons with patients, discussing about those cartoons. And then we made them colorful. Okay, so these are the cartoons. But we faced a few issues with the cartoons. For example, we started with this cartoon about lack of insight. Okay? Do you agree it's a lack of insight? Okay? Okay, lack of insight.
Just normal aging.
Okay. But our patients didn't like them. They didn't like this. Why? They hated the red nose first. They are thinking that the red nose is too stigmatized. Okay? So, that guy is, is there, but you can imagine, I have those cartoons for you. So, you realize that, you can imagine that what we have the other side. We try to kind of make that less stigmatized, and people love that. Okay. We receive some other kind of feedbacks about these cartoons. I'm not going to discuss about those, but we try to receive feedbacks to see how to optimize them. And even for women, we started from this one, they didn't like that, and we moved to this one, and they like this more. But over time, we realized that most of the patients even do not like this one. Why?
Because it's too close to reality.
It's close to reality.
It's a mirror of what's actually what their life potentially is like.
It's stigmatizing the family to male, female.
To male and female. One of the things that we realize that our patients, the community that we work in, most of them, they do not have a real family.
Yeah.
They do not have any significant other.
They're in a relationship.
Yeah, but they do not have that. They do not have that sense of relationship in a way this way. And we developed this, and they love that. So we moved and changed that to Wonder Woman, and they really they really like that. So kind of thinking how we can even make those cartoons in a way that would be relatable, and people start to like them. And even for other communities, thinking about, okay, what could be the other things that we can put from other communities inside that would not be stigmatizing, not kind of racist. So and it's not easy. It's not easy, it's complex. And even here in New Zealand, we have started to discuss with a few colleagues, okay, what are the cartoons or faces that would be more relatable for people in New Zealand without being stigmatized with a specific race. So that these are the things that we can think about together. So I'm hopeful that we will be able to have kind of even them in Maori language. So we have started to kind of find people who might be interested to help us to develop the Maori version here. Okay, so we try to provide the materials together and start with this material, okay? I'm going to discuss about those things together. I will do with you step by step. So we put them together in a workbook. I have a copy of the workbook. The workbook is always kind of something like it has spiral kind of binders, and it's really easy, not like this, but they're kind of really easy to use in the kind of setting that we kind of run. And this is the package that we developed from that. And the package has 4 sessions. So we designed that to be doable in the clinical setting that we have in terms of having 4 sessions. We usually do that every week, 1 session per week. But there are kind of inpatient units that they run that 1 session per day. And so they can do it in something like 1 week period of time for those who have kind of in a kind of shorter period of stay. So they can do that as well. So this is kind of the package that we develop in terms of the structure. And it has 3 main components. One component would talk about, okay, what are the brain functions that are injured? Okay, and how do they reflect to the normal life? And then what we can do to foster brain recovery. And then what are the specific exercises that we can do for our brain in the process of recovery. So this is the psychoeducational material that we provided. And we started to train our psychologists and drug counselors. And they liked it. So we realized that it's pretty much easy to train. It might seem a little bit kind of, people who, I mean, for those who are in the field of, let's say, psychology, drug alcohol counseling, nursing, they just feel that kind of neuroscience would be too much complex. That is my understanding so far. But I realize that these kind of sort of materials are much easier than most of the other kind of psychological interventions, let's say CBT, because I will kind of give you a few examples. I realize that it's doable to even have something like a 1-day workshop and train people for the entire package, and they can run the package. And this is the setting that we run these packages. We run them in something like group therapy sessions and kind of around the table or around the room. I mean, normal kind of group therapy that you do in any place. And these are the material. These are the kind of the samples of the workbooks that we use. And there are some kind of workshops that we have done, and I put a few of them online. So if you like, I will be happy to send you the YouTube kind of link to the workshop. And we are recording the workshop today as well. So I'm not sure if those cameras are on or not, but if they are on, probably we are recording them and we probably can use them. I mean, we usually put them out if somebody is interested to have the material. So that's the kind of our strategy, to put everything, whatever we have outside for others to use. And so we start from brain injuries and how we start to communicate that. Okay, let me just bring you the materials that we have and start from that, and we will move forward from that point together. You need to receive 6 versions, okay? Both male and female versions. So please pass by to get sure that everyone would take one. This is not the size that we are providing for patients. These posters are being printed in this size.
So you provide that size to people, or you provide that size to the people to take away?
None of them. I mean, these are the posters. So we are not providing posters to patients. We just mount the posters in the treatment center. So that is what we We just print them and mount them in the center. What we provide for the patients is what I showed you there, the workbook. All those materials are in the workbook, so we provide them with the workbook. Okay, those who received the first one there, the first poster, brain injuries, and those who have attention. Have you received the attention one? Who received that? They are in the back. Okay, Lisa, how many versions do you have? 6.
How many should we have?
6. Yeah. I mean, how many you received? You have already received. 6. Already have 6. Good.
We have one. We've got 3 different ones, male, female.
Yeah. Amanda, how many versions you have? Amanda, how many versions you have? 5. Okay, you do not have that. Okay. Brain exercise for women. Where is the brain exercise for women? The purple one, the feminine purple one. Who is holding the feminine purple one in his hands? Oh. Male blue one. So we have red, blue, and purple, male and female. That is the arrangement, okay? So we are starting from male red one. Please bring up the male red one.
Female blue.
Cool. Okay, so let's start from this one. I need a volunteer to help us to read those things. Donna, would you help us? Would you start reading the attention loud, bold, and loud?
I often experience...
We are in the attention part, number 1. I'm going to ask you to write down, consider yourself as a patient. We are going to read a scenario. You are going to write down your personal experiences with that attention deficit scenario, okay? That is how we run these classes. So, yeah. We like to have these material for each kind of attendees in the class, but yeah, we didn't have money or time or whatever, yeah. But by the way, you do not have this one, yeah. Somebody decided not to give you this material.
It was me.
Okay.
My bad.
So mean. Okay. This is how we designed this in a way that we read the attention part, and patients have space to write down their personal experiences with that specific scenario. Okay. We are going to do this together right now. Okay. So, Donna, you are going to read the scenario, and you are going to write down and add few things that you have experienced that you feel that your patient would be experiencing. Please.
I often experience the environmental triggers inducing an inability in me to control my desire to use my drug preference. Consider
a patient of yours and think about what would be their personal experience with this scenario. What are the attention deficits that they feel? Because we need that patients would have an experience in terms of, or kind of start to share an experience about attention deficit when we want to move forward for the next steps. That is what you need to have. You can use the red female one. You already have the red female one. The text is the same. So you can use the attention part from this one. Do you have this one?
Yeah.
Okay. Okay. Write down what are the things that you feel that people would be experiencing. What are the complaints that patients would provide you about their attention deficits in their own words? Donna, would you read that once again for us, and then we will ask others to share. What are the other, let's say, more general attention deficit that people might experience? Amanda?
Well, I don't know if I answer that, but I was just thinking like boredom, like often when people are bored, they lack of those users.
So they cannot find anything yeah, we will get to that point again. We will discuss about that as well. What else?
Forgetfulness about appointments.
That would be more towards the memory side. So these are some of the representation of memory, attention, okay? So, but when we want to kind of give them a better sense about attention, how can we do that? Okay? How can we give people a better sense? What does attention mean? Okay? I'm going to give you some of the exercises that we do for that. We realize that if you want to kind of talk about attention to patients, it's really good to have an attention game and then say that, okay, this is attention. This is exactly the muscle that is involved in this game, and you can feel that. So I'm going to ask you to do an exercise. Right now, I can just do that on the screen. So usually we give people kind of papers for that, but I'm going to ask you to do a task, and you are going to write the answer. I'm going to ask you about the answer, okay? Are you ready for that? So, how many three-leaf clovers we have here? No, you're not supposed to not to just be silent and try to count it. It's much easier when you have that in front of you, but yeah, that's another. But you are expert, so you are not, you have a better attention. Do you feel the pressure? Do you feel the pressure? That is focused attention. So when it's not about the number, it's just about feeling that muscle that is involved. So you feel the pressure, okay? Let me give you another example. So these are some hidden items here in this figure, and you are going to find it, okay? So you are going to have 3 minutes, and I'm going to ask randomly from you to come here and show us these 7 items. Who is ready to come here and show us 5?
I got 6.
5, please.
So spade, fish, whatever that comes.
Do you feel the pressure on your focused attention?
Yeah.
That is called your focused attention muscle, okay? Now you felt that focused attention, because we have different attention. So we have focused, divided, flexible. So we have different attentions.
About that frustration.
Yeah, the frustration is there as well.
Here it is. There.
There it is.
Underneath the airport.
That was mean, but yeah. Okay. And so you can imagine, we play these games in the class, and people are engaged, and kind of we discuss about those things. And I try to make that in a way that people not get frustrated as well. So just kind of keep a balance of people, because there are patients that are really impaired, there are patients that are really better. So you need to kind of keep a balance, not to make others frustrated, just feeling that, okay, there are people that are really better than me. Just keep a balance, but meanwhile making them engaged, and then they know, they felt what does focused attention mean, okay? And we provide them with some other kind of examples. And some of these examples are flexible attention, divided attention. So we try to provide them with a level of understanding about their cognition with just games. So that is how we move forward. And we provide some other examples. And that is how the package is designed. The package is designed to talk about a cognitive deficit scenario, okay, and then providing specific games that engage that specific cognitive deficits. Now, at the end of the day, they have a feeling that, okay, I have attention deficit, it is attention, okay, and then the next question is, okay, how can I help my attention? So that is how we move from one kind of cognitive deficit to the other, to the other, to the other. So that is how the package is designed. So let's, for the sake of time, let's go, let me just, there are some other things that I need to talk about, but and we provide them with a specific, let's say, attention sort of kind of games that they can do at home. Let's do a few memories as well, just to give you a sense about memory. Okay. Would you read the memory?
I believe my memory has been negatively affected by my drug use. I seem to experience involuntary memories related to my using, such as when I pass by or think about places where I would use. I am experiencing lapses in short-term memory, forgetting things as recent as what I have for lunch, and if I return a phone call, I feel like this may cause others to lose trust in me.
Does it make sense? Do you feel that this is relatable to patients? Okay. And then we ask them, okay, provide us with other examples of memory deficit in your life. That is how, the package is designed, okay? And then we start some games about memory. See this for 5 seconds. Which one was that?
Oh, wow. Yeah.
Which one?
It wasn't 5 seconds.
Okay.
I wasn't switched on.
Oh, no.
What was that?
That's B.
It's B. Okay. Are you ready for the next one?
Yes.
Okay.
A bit more time.
No. It was yeah.
Okay.
Okay.
Yeah. D.
It's D.
Which one?
Here's D.
At the back. D. Okay. Have you felt the pressure on both attention and memory? Have you felt your memory muscle? Have you felt that? That is exactly what we like to make. We like to make a level of kind of awareness about where is your memory? What does your memory do? And give people fun time as well, kind of doing these games in the class. So you can imagine that the classes are really engaging. So we play a game, we provide a scenario, we ask them to talk about their deficits. So the package meant to provide people with awareness. So we are talking about just a 4-session. So the entire time that they are spending something like 6 hours. So in 6 hours, we are not going to change their lives. We are just going to, in 6 hours, give them an idea about the deficits that they have, what do these deficits mean, how those things are going to potentially, and what we are expecting them is just having a better motivation for the brain recovery. Just having a sense that, okay, my brain is going to recover, and I know more about my brain. I'm going to help my brain to recover, and I really like to have a better brain. That is the final outcome that we are expecting at the end of the day. We like them to have more motivation for recovery. We like them to have better insight, and specifically trying to change what is happening in their life in terms of the brain recovery. That is what we try to do. That's the package is designed to perform. And I have kind of several other slides to give you some other kind of examples, but for the sake of time, we can kind of go out and kind of have a cup of tea, and then we will be back to kind of go for the next step. So that's kind of how we are going to work together. So this session was mainly focused to the education side. And then next session, we are going to be more towards the rehabilitation, more intensive interventions. Good.